Hello, everybody. It's Mark Carter from Modern Pain Care, and you're listening to the Modern Pain Podcast. And today I'm extremely excited to have somebody I've been following for quite a bit on social media and, more from his website and this project he has going that we're going to talk today, Dr. David Hanscom. He's a neurosurgeon, and you're going to hear some of the interesting journey in his career today, but we're going to talk a lot on this episode about the neurophysiology of pain and some of the things within that topic that have really caused us both, and more obviously from David's perspective, to kind of change his thinking and maybe his practice when it comes to caring for folks in pain. Before we do that, David, would you mind introducing yourself a little bit for the folks?
Yeah, I appreciate being on the show. I'm very honored to be here and excited to discuss one of my favorite topics, of course. But actually, I'm an orthopedic surgeon. I always teach my neurosurgeon partners that I always wanted to be a neurosurgeon.
Awesome.
They wouldn't let me. So I'm actually an orthopedic.
My apologies.
And I've been practicing spine surgery since 1986. And I just retired from active clinical practice 3 weeks ago. So I practiced spine surgery for over 32 years. And my practice was complex spine surgery, which probably over half the patients were patients who had had multiple prior surgeries. And it wasn't uncommon to see people with 3, 4, 5, 6 operations. My record was one gentleman who had 29 surgeries in 20 years. Wow. Another woman had 13 surgeries in 3 years. And so that's my practice, was trying to salvage those situations. And for the first 7 or 8 years, I was very aggressive technically. I was doing a very high-level program. And I was one of those people who thought that surgery was the right thing to do. I actually felt guilty if I couldn't find a reason to do surgery. And when I started in practice, Seattle had 9 times the rate of spine surgery for back pain as any place in the entire country, and I was part of that. So I would do clinic all day, then go down to the operating room and do surgeries in the evening. And we were doing 1 and 2 level fusions for back pain at that time. And I worked pretty hard at the rehab at the time, but the data came out about 7 years later that showed that the success rate in the state of Washington in a workers' comp patient for back pain surgery was 22%. So I just stopped. And I didn't know what to do. And then for the next 10 years, I unfortunately went into an extreme chronic pain burnout myself. And so it started with an anxiety reaction on the Lake Washington Bridge in 1990. And my philosophy in life was bring it on. I didn't even really know what anxiety was. So I went from essentially no anxiety to a panic attack in 1 day. And from that point on, it was like letting the cat out of the bag. And I had no idea what happened. So I eventually found out, I didn't come out of it till 13 years later. It took me another 5 years to have some hint at what was going on. And as you know, the neuroscience research explains exactly what's going on. So what I did, I treated the anxiety. I'm a major spine surgeon. I did not get to be a spine surgeon by being a wimp. And again, I was the opposite. My thing was bring it on. And I did. And then to go from that to having anxiety reactions was unbelievable. But that's how this whole process started. So I like to go into what happened now. There's lots of things in between we can talk about. But what I've since found out that we tend to treat anxiety as a psychological issue, right? That's a general flavor. But the problem is it's not. It's actually a neurochemical survival response. So what happens, you have a threat, physical threat. Your body secretes adrenaline, cortisol, and histamines to ward off the threat. And then when your body's full of these stress chemicals, then you feel anxious. So anxiety is that feeling generated by the body's stress chemicals. The reason why it's so critical to what we're going to talk about tomorrow as far as the physical therapy application of these concepts is that neurochemical survival response is 100% of every human being. We wouldn't be alive. It's 1,000,000 times stronger than the conscious brain. It's not subject to psychological intervention. Now, psychology can help, but it's not the primary modality. The reason I'm being really clear on that, the way you decrease anxiety is you decrease the stress chemicals. So once you find ways to decrease the stress chemicals, then the anxiety drops. The problem is if you treat it with, so the problem is you have a physical threat, Every living creature has an anxiety type reaction that causes them to take evasive behavior, problem solve. It shows out in the neuroscience research that thoughts do the same thing. Thoughts go to the same area of the brain. They secrete stress chemicals that you feel anxious, but humans can't escape their thoughts, right? You can suffer with them, suppress them, or mask them, hence the opioid epidemic and other addictions. But what I did, what got myself in trouble in retrospect, is that here I'm this really tough spine surgeon, really tough, and I was a master at suppressing it. And what happens with lots of professionals, particularly surgeons, is that we're masters at suppressing stress, but your body doesn't believe it. Your body still pulls all these stress chemicals. So it turns out that the mental threat is a bigger problem than the physical threat because you can't escape the mental threat. You end up with a sustained chemical response and you develop multiple physical symptoms. So the mental pain actually translates into physical symptoms. So at one point I had 17 of these symptoms. There's over 30 potential symptoms of an adrenalized nervous system. I had 17 of those at the same time. And I had no idea what was going on. So since I thought anxiety was psychological, couldn't figure out what was going on, I actually went into psychotherapy for 13 solid years. And things got way worse. But although psychology, I don't want to dismiss psychology because it is valuable, but it's not the primary treatment. So what I didn't realize is that the more I talked about the problem, the more attention I paid to it. And so I actually reinforced these circuits, not solved them. So what happened by 1997, I developed a full-blown obsessive compulsive disorder, which is an extreme anxiety disorder. And I was in really deep trouble. And I was so good at suppressing anxiety, my body chemistry was way off. So some of the symptoms I had were migraine headaches, tension headaches, neck pain, back pain. I had ringing in my ears, burning in my feet. My scalp would itch. The skin rashes would pop up. Because what happens is that sustained stress chemical response affects every organ in the body. That's why there's so many different symptoms. So the key issue about everything we're going to talk about going forward is this basic concept that you survive by processing sensory input. Your nervous system sums it up every millisecond. The sum total is either positive relaxation chemicals like dopamine, oxytocin, cortisol, and the GABA drug. Not cortisol. Dopamine, serotonin, the GABA drugs, and oxytocin, or the stress chemicals. So when you have these pleasant chemicals, you feel relaxed. So again, the relaxation is that sensation generated by the relaxation chemicals, which again is much more powerful than the conscious brain. So I call it the curse of consciousness, is that we can't escape our thoughts, and we have these sustained chemical reactions that make us sick.
Yeah, and it's interesting. If you take that all full circle and you think about how our healthcare system views pain, and I know you're obviously an expert in seeing how that didn't maybe work the best for you. And I think that's always interesting when I talk to people like yourself and others who really, when going through it, was probably the biggest education they've ever experienced. Although, it was a long period of time for you. You mentioned, but
right.
How do you think? From a systemic side, I know you're doing you have your movements you're doing over there in your neck of woods up in the Northwest. Do you think healthcare is just, I don't want to say doomed, but what are the things that we need to change, and what are the things maybe you're doing to change with all this new pain neurophysiology in mind to help us better recognize those things? It sounds like obviously there's an educational shift that needs to happen.
Well, the story is that pain represents an injury. And as you well know, pain is just an output, it's not an input. So the input is all these sensations that are either positive, neutral, or negative. So our body automatically acts in a way to keep us safe, called the nociceptive system. So this is what's frustrating to me about the medical profession right now. This is actually high school chemistry, maybe even middle school science, is that when you're under stress, your body secretes chemicals. Your heart races, you become short of breath, or your breath starts to race, you start sweating. And those are real physical changes based on body chemistry. So although you can't see the chemical changes, you're obviously having real physical reactions, and when it's sustained, people get sick. So the thing that I actually quit my surgical practice at the peak of my career because of this problem is that the neuroscience has become very clear what the problem is. Again, I think it's just confirming our high school science class that when you have sustained levels of stress chemicals, you get sick. And so as you calm them down, you heal. But what we've done is said, well, if there's pain, there must be something wrong, let's fix it. The medical profession has gone completely off base. We're actually not practicing medicine anymore. And actually in spine surgery or spine care, almost every procedure that's covered by insurance has actually been documented to be ineffective, right? Facet rhizotomies, facet blocks, epidurals for axial back pain, spine fusions for back pain. I mean, none of these modalities work. Things that do work is mindfulness-based stress reduction, good physical therapy, stretching, strengthening, nutrition, diet, etc. So those things have been documented to work, but they're not covered by insurance. So right now, mainstream medicine is literally pretending to practice medicine. The way you solve chronic pain is you decrease the body stress chemicals. And what you're doing with the tools to solve the problem is you're literally learning how to optimize your body's own chemistry. There's two ways you do that. So one of them is directly lowering the stress chemicals. That's where mindfulness comes in, meditation, relaxation, exercise. All those decrease the body stress chemicals. As the chemicals drop, that feeling of anxiety drops, the physical symptoms start to disappear. The second thing is, which is more important, is that we call it neuroplasticity, where actually change the structure of your brain. So what you're doing, you're wiring a different response. In other words, we have stress or threat. There's always an automatic survival response, right? And what you do, you create a little bit of a space between the threat, a little bit of a space, different response. You have a choice of responses. As you become aware of the stress, as you become aware of your response, you create a space. So in that space, you substituted a different response. So with repetition, you literally create a different part of your brain. You actually reconstruct your brain. Because your nervous system changes every second. We didn't know that in medical school. When I was in medical school, I thought the brain was static. You'd only lose cells as you get older. But we didn't realize your brain changes every second. So there's a bunch of tools to do that. And so you think in terms of neuroplasticity, the sequence is awareness, separation, redirecting or reprogramming. So there's a lot of ways to do that. The way we start with that is a tool called expressive writing. So if you write down your thoughts, remember you can't escape your thoughts, and you immediately tear them up. Destroy them, burn them, whatever you want to do, but you immediately tear them up. You can't escape your thoughts, but you can separate from them. So the thoughts are in paper, you're here. There's a space now separated by vision and feel. And it's not the solution, but it's the only one mandatory starting point of the whole process is what we call expressive writing. It can be positive or negative, it doesn't matter. And to me, it's just a metaphor. In other words, there's trillions of thoughts. You're not going to solve them. And you tear them up for two reasons. One of them is to write with freedom, whatever thoughts come in. The second one is to not analyze them because your brain's going to develop wherever you place its attention. So the way you really start changing the reactivity of the brain to have less stress chemicals is like developing a new language in your brain. So you have awareness, separation, reprogramming. The reprogramming can be relaxation, visualization, good food, good wine, good friends, play, etc. So you can't really, if you're using these other modalities to fight the anxiety or pain, you're going to lose. But if you separate first, in other words, you're okay, you write things down, separate, that's the first step, then the reprogramming tools work. But what you're doing with repetition, you're literally creating a new nervous system within your old nervous system. The metaphor that I've been using recently, which has been very helpful for me and my patients, is learning a new language. Let's say you want to learn to speak Spanish. You're going to take the classes, read the books, listen to the tapes, maybe go to Spain for a year. But let's say right now in 5 years, you can speak Spanish. What happened? Right? Something, your brain changed, and now you speak Spanish. You didn't learn Spanish by avoiding speaking English, right? So by not speaking English, you didn't also learn Spanish. It took lots of repetition to make that happen. Remember, pain impulses come into the brain the same way. It's repetition. So it's a programming problem, and pain does get memorized in about 3 to 6 months in the brain, just like almost any other skill that we do. The problem with pain impulses is they come in so quickly that instead of taking 5 years to learn Spanish, you've now learned this language of pain in about 3 to 6 months. So the metaphor is you can't solve chronic pain by trying not to be in pain because your attention's on the pain. Just like you're not going to learn Spanish by trying not to speak English. So what you're doing is you're creating a new nervous system, a new language I call an enjoyable life. Because remember, the default language is survival. Remember, the species that survive this very minute as we're sitting here, out of millions of years of existence, we represent the most anxious species. Because the species that didn't pay attention to their environmental cues didn't survive. So what you're doing, you're literally creating a virtual desktop on your computer or in your brain that now instead of being stress, automatic survival response, you have stress, choice response, and it's a learned skill with repetition to learn how to enjoy your life. So that's the key issue is so you think in terms of neuroplasticity and not psychology. It's a completely different paradigm.
That's interesting, with that paradigm you speak of, that whole threat and response thing, it's kind of, definitely not to the degree of like some of the CBT stuff, but if you think about like exposure-based therapies, which are part sometimes of the psychology, where you're trying to expose someone to a threat,
right,
and hope to achieve a different response
right.
through like a graded exposure program. And that's something we use in physiotherapy a bit, is graded exposure,
right.
And more out of that kind of, operant conditioning, classical conditioning, I should say, where we're trying to, disrupt that pair of this threat with this unconditioned or conditioned response. Now we're trying to achieve a new response. So it's interesting to see the parallels there. Neuroplasticity.
That's the exact parallel. You're doing it in a physical realm, but mm-hmm. You also do that with thoughts.
Yeah.
See, what CBT does, what cognitive behavioral therapy does, for those who aren't familiar with it, is that you're challenging maladaptive thought systems, right? Mm-hmm. So one of them that physicians have commonly got me in deep trouble is perfectionism, the word should. So we have this word should in our heads, and what Dr. Burns calls in his book, Feeling Good, a cognitive distortion, is that word is always there, and it's based on stories about yourself, and they're cognitive distortions that create this unpleasant chemical environment. So by becoming aware of what that word should does to your body's chemistry, what CBT does is substitute thoughts. Remember, thoughts are input, pain is the output, or anxiety is the output. And from my perspective, anxiety actually is the pain, mm-hmm. right? And there's 3 parts to any pain. There's actual impulse, then there's the cognitive component, okay, this just happened. Then there's the emotional component, which to me is the body's chemistry. So there's always 3 parts to pain. And so pain's not just put your foot on a nail and it hurts. You have to actually be upset about it. So people, when I was in the construction world, I actually almost ripped my thumb off with a 28-ounce framing hammer full swing. And I literally stood up, took about 3 seconds to look at it, and went back to work. I don't think that would happen today. I'm not sure what I was thinking that day. But in another circumstance, if somebody else had taken a hammer and was hitting my thumb, I'd be screaming, right? So the circumstances make a huge difference in your perception of pain. I do like talking to the physical therapist because your culture has really worked on this whole neuroscience of pain. None of this, I swear, has really penetrated mainstream medicine at all. I'm sure you're well aware of that, mm-hmm. right?
Definitely. It's one of our frustrations, and we would just all drool if we could get like physicians and nurse practitioners and stuff to attend some of the, lectures and stuff and coursework we do
right.
with it. One thing, to circle back, because you bring up a lot of the symptoms you had with a lot of these, symptoms of the adrenalized system, or this, kind of sensitized nervous system, you might say. How much do you think out there in healthcare of these, widespread pain conditions, and some people will call them functional pain syndromes, fibromyalgia? Do you think there's just a lot of common threads in those diagnoses where our body materializes a lot of of some of the, like you said, of those 30 symptoms. I'm not exactly sure the entirety of the list that you talked about, but I think we're in this such a system that wants to put people in these nice little buckets and neat buckets that fit some definable pathology. But do you think we could strip it back and just look at a lot? I sometimes wonder, like, we're calling all these different kind of maladaptive ways that our system can present itself when it's struggling with stress and the sensitization that you speak of, that maybe we're all just dealing with the same, same way. It just materializes itself, or same thing that's materializing itself into different ways. Maybe it's pain in the back. Maybe it's a dysregulated GI system for IBS. Maybe it's a migraine headache for another person. What are your thoughts on that?
Yeah, absolutely. I mean, I'm writing another book, which I'll probably never finish this one. It's called The Curse of Consciousness. So my hypothesis, let's take mental health, for instance. Mm-hmm. Remember, anxiety is a sensation generated by the body's stress chemicals. It's 1,000,000 times stronger than the conscious brain. It's not subject to conscious intervention. You can't control it. You can direct it, you can retrain it, but you can't control it. So my hypothesis is that anxiety essentially drives every mental health diagnosis. Let's take depression. The first sign of depression is waking up in the morning and not falling back to sleep. Well, that's racing thoughts. Then you can't fall asleep. Again, racing thoughts. Then you can't sleep. Another sign of depression. Then you can't concentrate, which is a combination of lack of sleep and anxiety. Then you have fatigue, which is from an adrenalized nervous system. So my website post I'm actually going to write this week is basically depression is anxiety. So in other words, depression is just a constellation of symptoms driven by anxiety. Let's take bipolar, clearly an anxiety disorder. ADHD, what drives people's attention problems is anxiety. Let's take addictions, alcohol, substance abuse, opioids, whatever it is. 40% of my entire surgical practice is with infected spines. 2/3 of those are from IV drug addiction, drug addicted patients who inject IV drugs into the arm. Bacteria gets into the bloodstream, it lodges on the cardiac valves or their spine, and it can't get out. So then they're in the hospital for weeks trying to get better, and they're crippled with anxiety. It's not the physical pain that bothers them, it's the mental pain. When I went through my process, I had all these physical symptoms, but it was the mental pain that was the worst of it by far. So again, it's the anxiety itself is a chemical reaction. So there's lots of anxiety-related disorders. What drives addictions is anxiety. Now, with some addictions, of course, they get a hyperactive reward center, so they get more dopamine maybe than the average person. But nonetheless, people want to escape their anxiety. Eating disorders, body image disorders. So obsessive thought patterns are anxiety-driven. Anytime you're anxious or frustrated, there's something in your past that got triggered. In other words, if you're on a nice day looking out at the breeze, no big deal. You're not anxious. But if somebody walks by that resembles your high school person that bullied you, what happens, right? So how did that happen? Your heart starts to race, your muscles tense up, correct? So your body had an automatic adrenaline surge, and you don't even know why. Maybe you don't even recognize the relationship between that person's body image and that person who bullied you in high school. So physical symptoms, same thing. So adrenaline, cortisol, for instance, you have elevated histamines, which compromises the immune system. So that's a problem. Migraine headaches, what happens is adrenaline constricts the blood supply to the brain. And when I had migraines for most of my life, they'd always occur on a Saturday when I relaxed a little bit. So you have this ongoing constriction of your blood vessels. You relax a little bit, blood vessels expand, pounding migraines. Adrenaline affects the blood supply to the gut, so irritable bowel. It affects the blood supply to the bladder, irritable bowel. The stress chemicals double the nerve conduction. So your nervous system gets sensitized, and from a survival standpoint, that makes sense, because if you're threatened, either mental threats or physical threats, every living creature is designed to be hypervigilant and watch out. One of the most aggravating symptoms I experienced was ringing or tinnitus. So I had ringing in my ears for almost 20 years. I thought it was from a construction injury days. It's gone. Who would have thought? But what happens again when your body chemistry changes, then it improves the nerve conduction, these symptoms start to disappear. But picture this. I mean, really, your sense of well-being on this planet is based on your body's chemistry. Picture yourself full of oxytocin, the love drug, serotonin, antidepressant, dopamine, the reward chemical, the GABA drugs, which are like Valium and Xanax. So picture your body full of those when you're at play, relax, have a good time. Your body chemistry, everything's great, right? And your body responds in kind. So when you're stressed and chronically stressed, right, your sense of well-being is very poor. So by definition, you're anxious with those chemicals. By definition, you're relaxed with those chemicals. And so again, what you're doing with these tools has very little to do with psychology. It's about regulating your body's chemistry. So that's the key issue here. And you can, and pretty soon your body becomes a feedback loop. I can feel great, not particularly anxious. All of a sudden, these little skin rashes pop up in the back of my wrist. Or my wife laughs at me because I just start scratching my scalp a little bit. And then I have to take those physical cues and work backwards and go, well, what triggered me? What's going on? And usually I can figure it out. But your body's not going to lie. You can psychologically suppress almost anything, but your physical symptoms are not going to lie. So if you just visualize your body in this beautiful chemical bath when you're at play compared to the chemical bath when you're stressed, it's a big problem. And the lifespan of people in chronic pain is significantly lower. I think it's about 7 years shorter than people who without chronic pain. There's a major paper out of Sweden about 6 months ago in our Journal of the American Medical Association, where they finally documented a very clear link between chronic stress and autoimmune disorders, which makes sense. Remember, the stress chemicals affect the histamines. So, I mean, autoimmune disorders don't just happen. I mean, why is your body going to attack itself? That's not normal. So they showed a very strong link between sustained stress and autoimmune disorders. Well, I mean, if your kidneys failing, your liver's failing, you have skin rashes, your eyes are doing different things, and those are real physical symptoms, that's not really psychological, right? It's an unpleasant body chemical environment that's influenced by the psyche. But again, the psyche itself is just a fraction of this response. You can't control it with the psyche.
Yeah, and I think you bring up some great things, because I think it's a good representation of how we want to kind of compartmentalize. It's either psychological, it's biological, or it's social, but does the human body even make those delineations with how it behaves? Like, can you put it in those buckets where you embody your emotions, you embody, like you said, some of the things that happen with anxiety, the physiologic changes, but yet you see what we do in healthcare is where we interrogate the biology to the nth degree and forget that maybe this biology is presenting itself because it's embodying a lot of the things you've so nicely described here today. I'm just curious, how do we position ourselves as a healthcare system? I know you've done it within your practice and the way you've I'd love for you to share how your surgical practice may have changed as far as your operative rates. I know I've listened to you on other podcasts and stuff about what it took for you to change as far as how you approach the patient with that neurobiology involved and neuropsychology or neurophysiology in mind, to maybe change how people's outcomes and trajectories went that traditionally would have probably been maybe a surgical candidate.
Well, a couple things. First of all, before we go into that question,
a
really good point is that I want to come up with a different term. So we use the term mind-body syndrome, which still implies a separation, correct?
Yes.
And so the key issue is trying to picture flying a Boeing jet plane without a computer. How's that going to work?
Not well.
How do you have an orchestra without a conductor? Not going to work. How do you have a football team without a coach? Not going to work, right? Mm-hmm. So the human body is trillions of times more complicated than any of those things I just mentioned. So it's just a unit response. There's 80 billion brain cells. There's 50 trillion cells in the body. There are 1 million pain fibers per square inch in the body. So everything's intertwined. It's just a unit response. That's why when you have anxiety, your stomach goes nuts. It's just a bodily response. And the nervous system happens to be housed in the brain. Humans did develop consciousness about 70,000 years ago, but before that, it was just simple threat response survive, right? And so this language thing makes things much more complicated. And obviously gives us a advantage in the food chain. But as far as our bodily reaction to stress, this consciousness thing made us really in a lot of trouble. So what's happened is that the number one thing in medicine right now that's a huge problem is that we've assumed pain equals damage. Pain is just a response to input. Pain does not equal damage. What's changed my practice dramatically is that I was taught, like everybody else, that if you have a bone spur and it matches the pain, it must be the source of the pain. Or if you had pain without an obvious source, the pain must not be real. Pain's always real, but it also turns out whether the pain comes from a structural problem that you can see or from an inflammatory process you can't see, it still hits the nervous system the same way. You still get the same chemical response. So it actually doesn't matter where the pain's coming from. What's happened in my process, the data shows very clearly that if you operate and do surgery in the presence of chronic pain, and I didn't know this for a long time, that you made the pain way worse up to 40% of the time for up to a year. The nervous system is already fired up. You know, let's say, for instance, you have chronic low back pain and you have a hernia repair. Well, hernia repair is a pretty simple operation. Pain's gone within a week usually. You can induce chronic pain at the hernia site up to 40% of the time. When you have back pain, two different parts of the body, right? So on the surface, that doesn't make any sense, right? But you know that the brain's fired up, you start plugging in body parts, and patients aren't told that. They're not told that chronic pain could be a complication of a simple hernia repair. But the pain's not in the back, the pain's actually at the hernia site. So when we started about 5 years ago, we called it prehab, and my nurses started this, is that we noticed when patients were going through the things that affect outcomes like better sleep, stress management, physical conditioning, exercise, etc., that the surgical outcomes were spectacular. And patients that just wanted to be fixed, the results were sometimes good, but a lot of times they weren't very good. And I used to teach my fellows. I mean, occasionally we have surgical failures, but honestly, the last 5 years, we just had endless patients come in after elective spine surgery doing incredibly well. Then what happened, I had patients with structural problems. In other words, they had pinched nerves. You could see the bone spur. There's a syndrome, as you well know, is called spinal stenosis, where the spinal canal is narrowed down to about 6 or 7 millimeters. And the canal is normally about 15 millimeters in diameter. These people would come in with canals about 6 millimeters in diameter or smaller, very tight stenosis. They would have pinched nerves and leg pain, as you would expect. But as we went through what we call a prehab process, pain disappeared. They actually never had the surgery. It happened in over 100 patients. So what happened to me is that my surgical practice was already not very yielding as far as the number of patients I saw versus surgery. So I was at the usual maybe 8 to 10%. And then a lot of surgery practices about 20 to 40% of the patients get surgery, sometimes even higher than that. And after we started doing what we call prehab, my surgical rate dropped to like 4.5%. So it devastated my surgical practice, right? But these patients weren't just living with the pain would disappear. And I'm going, what? And they're going, what? So it's fascinating to watch. So even with structural problems, and they would have done okay with surgery, they would have done fine. I actually had them on the surgical schedule, and they canceled the surgery. The biggest issue facing medicine right now is that often people come into the doctors with symptoms, but I would guesstimate about 80% of the time there's been some major life change that's changed the body's chemistry, it's changed the pain threshold. The bone spur has been there for decades or 5 or 10 years. All of a sudden they have leg pain. Well, it wasn't a ruptured disc. The bone spur is already there. Something changed. But what changed was the body's chemistry. So what I've learned, and I'm much better at this than I was years ago, is just ask a little question, well, what's going on? And invariably, something pretty severe. Suicide in the family, divorce, loss of a job, child with cancer. I mean, endless stuff. People under a lot of stress. They've always been under a lot of stress. I'm not even saying it's worse now than it was, but once we just let the person just calm down for a few weeks, even without much treatment, pain goes away. the problem right now is happening with the corporatization of medicine in this modern era is that we're, again, treating pain always as a structural problem. And then we've invented procedures that make a lot of money to deal with these problems, and they don't work, number one. So essentially, every procedure in medicine, as we mentioned before, at least in spine surgery, has been documented to be ineffective. So we're literally pretending to do medicine. We also know the way you induce depression is you repeatedly dash hopes. So you come to me as a doctor, you trust me to do the right thing. I prescribe a treatment that the data says doesn't work. There's a paper out of Baltimore that says that only 10% of surgeons actually acknowledge the risk factors for poor outcomes. Only 10%. The biggest problem is happening right now is that doctors are not being given the time to listen. And my book is a book, it's a framework that provides a rich platform for conversation. But what really is happening in this process is the patient is connecting with his or her capacity to heal. That's it. Not a magic formula. It's not like 1, 2, 3, and I'm fixed. So it's a process of allowing yourself to heal. And so what I found out is that as I went through my pain process, I developed much more empathy for my patients in pain. I mean, it's like everybody, I was like everybody else, what's going on? Can't see what's going on, must be in your head. Well, first of all pain's in your head. That's how it's interpreted. Second of all, I didn't understand the suffering that people were going through. And I was in this hole for 15 solid years, and I know it to a millimeter what they're going through. And it's a bad deal, really bad. So I learned as I healed myself, I was then able to connect with my patients, which helped them connect with themselves. And the bottom line is that patients can actually take their time, feel listened to. It's the biggest factor right now that's been taken away from us. We don't have the time to listen to our patients. So, okay, so we're doing all these medical interventions, and maybe your spouse is beating the heck out of you. It doesn't matter what we do in the office, right? And I mean, the variations in that story are endless. It's common. So I'm actually starting a movement called Take Back Medicine. And my proposal is to markedly, dramatically increase the fee schedule for talking to patient, and also mandate stress management for physicians. But if you have a burned out doctor and rushing through the day, not talking to his or her patients, everything we've talked about doesn't really work very well. So the number one thing as far as healing is connecting to your own healing capacity. And that happens in a healing environment with your provider. That was a very long answer to one question. I don't know if I...
No, I think that was great. And this is something I've harped on in our group that we lead on Facebook, as far as we need to bring the patient's narrative back into medicine, the humanity back into medicine, because we so miss a lot of those exact things you said. I think when we're privileged in the physical therapy profession to often, although not all of us, to have an hour with each evaluation. And I tell you, a lot of times with the chronic pain patients, a good chunk of that first evaluation is just shutting up and listening and letting the patient in. And you're right. I think, and we've talked about this in our group, is you hear a lot of things surrounding somebody's pain that are pretty significant traumas, emotional, psychological traumas that people have been through. But they've then navigated a system that then wanted to biologize and pathologize, and then again, oftentimes we just take natural history and aging and try to make that be the problem, which is probably another discussion.
Right.
But, I think it's a refreshing perspective to come from a orthopedic spinal surgeon to hear that. I think you bring up some other things about, how challenging that was for your practice. Like that's a devastating thing for your surgical practice to lower your surgical rates to that. And I think those of me listening and those who are listening, I know are hugely appreciative of the courage that takes, and to really turn the back. I don't want to say turn your back, but to look beyond maybe the financial incentives, because we're all humans. I mean, and we all are motivated by certain things, but to go through what you've gone through and to then, give it back to your patients, and then to, really change completely your course of your professional career, even though it may not be the most financially lucrative. I think, kudos to you for that. I think that's hugely impressive. And Something, that's probably a hard transition to expect from a lot of physicians, but yeah, I mean, hopefully I think you are a pioneer in this, and I don't think I can thank you enough for what you're doing.
Well, I appreciate that. The thing is, I mean, I actually view myself a little differently. Is that these concepts have been around for centuries, and then in 1927, Dr. Francis Peabody wrote a paper out of Boston, it's a very famous paper. But the final sentence was that the essence of care is caring for the patient. And he was concerned in 1927 about technology coming in and interfering with the doctor-patient relationship. Okay, so that's 100 times worse now, right? So I prefer to look at myself as sort of carrying a torch that's already been lit. And I'm not sure, I think it's the corporatization of medicine has buried this pretty badly. And unfortunately, what happens when we do procedures, and as far as me doing surgery or not, after 32 years of doing surgery, a certain number of people get complications. It's just the way it is. There's a certain balancing act being a spine surgeon that's tricky. And unfortunately, when people get complications from an operation in spine surgery, the results are devastating. So what happens if you have a surgeon that maybe didn't need the surgery or maybe could have done it without? I mean, I'll never forget, back in 1997, I was doing surgery on a guy who needed a pretty big operation, who now, knowing what I know, I could have rehabbed him. I didn't know it back then, right? So surgery went beautifully, didn't lose much blood. He woke up completely blind. That changed my life. So I had another woman who did a 1-hour surgery. She had a dural tear, a little bit of bladder retention. She developed an infection in her bladder, E. coli. She died, septic shock, 1-hour surgery. So nobody plans on having a complication. If you were planning on having a complication, it wouldn't be a complication, right? And so that happens intermittently over your entire career. You don't know exactly when it's going to happen, what the situation is going to be. But it really wakes you right up that every surgery has a risk to it. And so most surgeons I know as they get older actually do start dropping back quite a bit. But nonetheless, what's disturbing to me, if I just known then what I know now, there are dozens of patients who would have a much better life, much different life.
Yeah. Yeah. I mean, I think any career you kind of look back, I know we often will trade discussions of patients. We wish we could go back in time and do things differently as far as, in our realm, it's a lot of the, hammering on people's biology when we just needed to shut up and listen and just give their body permission to heal instead of pathologizing and moving it into, we always call it like movement jail and all these rigid rules around, things that theory really isn't held up for in our profession. So I think definitely not maybe as obviously as dire of consequences of some of our past errors, but I appreciate you sharing that. That's, some of the things that define our career, I think, are like can be big career changing events, not pleasant ones to go through, but, things that'll help us,
Well,
change.
I think the main thought I'd like to leave with the listeners is the bottom line is just think of the words neuroplasticity. Your brain's going to develop wherever you place its attention, number one. Second of all, your quality of life depends on your body's chemistry. So in the physical therapy setting, there's a bunch of things you can do in that setting that make a huge difference. And to give you one hint of it, one of the rules we've developed the last 3 years or so is we never let people discuss their pain because that's where your attention is, right? Mm-hmm. Now, hearing the story once is fine. That's it. But no complaining, no discussing medical care, no discussing their pain. Because what happens to things in terms of neuroplasticity, that's where your brain develops. So anyway, that's just a hint at what we'll talk about tomorrow with the overall how to really do physical therapy in a way that makes a huge difference as far as chronic pain outcomes.
No, I can't wait to talk more about it and hear that new language that we're going to teach people. It makes complete sense to us that let's not keep speaking the pain language. Let's give people a new language to discover and discuss and explore. So I love it. I can't wait to hear that. And I just want to thank you for your time today. We'll be touching base tomorrow to get part 2 of this story, and hope you guys tune in.
Great. Thanks a lot. I appreciate being on your program.